Hello everyone, I'm Louise Thomas. I'm the Clinical Network Programme Manager from the North West Coast, and I support Lancashire and South Cumbria ICS with their suicide prevention programme.
And I'm Vicki Wagstaff. I'm a Clinical Network Manager working within that team on self-harm, suicide prevention, bereavement support, dual diagnosis and depression care.
Okay, so we're just going to give you a very sort of quick background as to our ICS footprint, a little bit about where we were when we first sort of got told that we were able to access the Wave 1 funding, and the work that we'd already put in place that set us on a good sort of footing to then mobilise all the work that we've done over the last 2 years. And then Vicki will talk around some of the engagement and the co-production work that's been involved, that we've done for some of the work programmes. And then we'll talk a bit about COVID as well and the impact, the massive impact that's had on our work programme. So Lancashire and South Cumbria is an ICS. It's a partnership of NHS, local authority, public sector, voluntary, faith, community and social enterprise. We work to a population of about 1.7 million residents. Do you want to go to the next slide? So when we first started on this journey as a Wave 1 site, unfortunately, Lancashire and South Cumbria had the 4th highest suicide rate at the time, and that's why we were identified as a Wave 1 site. 2 of our districts, which were Blackpool and Barrow, one had the first, and I think Blackpool had the first and Barrow had the 3rd highest suicide, highest self-harm admission rates in England. And at the time, just as we sort of received this funding, we were moving from an STP into an ICS, which is now fully established. So before we became a Wave 1 site, we'd done a lot of sort of groundwork. And I know there's lots and lots of people on this call, so I'm not going to go into lots of detail, but we had the partnership right. We had the key sort of stakeholders, and we went on a journey together. What we did initially was looked at all the local authority suicide prevention plans. We reviewed that against all of the policies and documents that were out from National sort of Public Health England, from the government, and then we used that to identify any gaps. Where were there areas that we could do things once, the economies of scale? And what we did with that, with our partners, we developed our logic model. So this logic model is an action plan. What you can see on the screen there is just the sort of front sheet. What sits behind that is a very detailed sort of work, an action plan. So we've got 3 long-term outcomes. We've got long, medium and short-term outcomes, and we've put them into pillars. So we have a leadership pillar, a prevention pillar, an intelligence pillar, a postvention pillar, and an intelligence. Did I say intelligence twice? No.
Yeah, you meant intervention.
I meant intervention. There you go. So it's because the slides are dead small, Vic. So I'm like going outside. So we've had that in place, and then what we did when COVID sort of hit and we went into lockdown, we then reviewed that plan, and we've developed a COVID specific suicide prevention plan that aligns with a lot of the information that came out from NHS England, from Claire Murdoch's letter back in March, on what we should be refocusing our sort of priority areas during that pandemic. Obviously, we're now, the Northwest is back into nearly full lockdown, and in that tier 3. So, we're working our way through that. But again, it aligns to those 5 pillars. Do you want to go to the next slide? So our motto in Lancashire and South Cumbria is that suicide, yes, you can get copies of the presentations, yeah. Suicide prevention is everybody's business. It's not just it's not just public health. It is absolutely everybody's business. Our private sector, our third sector, everybody needs to be have suicide prevention as part of their core sort of business. So what we've done is we created a whole system approach. So we've developed, we've had community feedback sessions. We've had information events, looking at you said we did, what is it that we need to do. We've embedded suicide prevention into NHS England, CCGs. We've developed suicide prevention policies for staff. Maybe some of your organisations don't have suicide prevention policies, that are within that sort of suite of health and wellbeing policies. Suicide is probably not really mentioned in them. So we've developed for our partners, and anyone, we can share that policy. They can have it and adopt it and use it, because we feel that suicide prevention needs to be its own standalone policy as well. So in the first year, that was a lot of the work that we focused around. It takes a long time. You've got to get those relationships right. If you're trying to set up a real-time surveillance system, which thankfully we did, it takes, building that relationship up is actually key to getting that information sharing, understanding what you're going to use that information for, how you're going to use it, how's it going to make changes within your system. All of that takes time. Again, within our first year, we had delays. It's not all been singing and dancing. We had delays in procurement, which delayed some of our work. Procurement takes a long time. So if you need to make sure that you take that into consideration, if you're just starting out as a wave 3 site. For year 2, we've built on the projects that we sort of started and have run with them. Vicki, is that your mouse? Do you want to talk a little bit around that?
I can do, yeah. So year 2 is a real doing year. So you get everything set up, get it all in place, get things working, the relationships running. And then in year 2, we really dug in and tackled those 22 short-term outcomes. The reason I've use existing systems where possible, you're asking people to possibly not go to another meeting. We found that was quite difficult, so we used as much as we could things like health and wellbeing boards, other groups that are already set up and actually get suicide prevention on their agenda. So it made it simpler to get in the front door in a lot of places. And utilise all the information that you've got from year 1. So we did a lot of community feedback and lived experience work, and that actually built a lot into the projects. So, yeah.
And then what we've been able to do is use our data, so real-time surveillance data, and we haven't obviously got time to sort of go through our system because we've done that previously, but that's enabled us to do targeted work. And more so for this during the COVID period, and Neil's on the call as well, we've used that data to support our campaign, our suicide prevention campaign. It's enabled us to target the messages into localities that have high rates of suicide. We've targeted on bus stops that have had numbers of suicides in their area. And without that data, we wouldn't be able to know at all. We wouldn't be able to identify. It would be stick a finger in the air and just say, yeah, we're going to put some information in there. But being able to be intelligence driven has really supported the work that we've done. Do you want to go to the next slide, Vic?
Yeah.
Is this me?
Yeah.
So setting up a whole system input. So we've got a suicide prevention oversight board. We cover 4 local authorities. We've got, I think it's 6 CCGs, a police force, NWAS. But we're lucky because we've got 1 trust on our footprint. We have membership from a wide range of stakeholders. And then what our local authority colleagues have done is they've set up local suicide prevention groups underneath that to sort of drive that further down into the grassroots level. We've had steering groups established for each of the work streams that sit underneath the pillars. So we've got self-harm that Vicki does, bereavement and dual diagnosis. And then a main part of our work and the main sort of spend that we've used the funding for is around training. We've now trained over 3,500 people across Lancashire and South Cumbria, which we've also had independently evaluated by Liverpool John Moores University around the impact of that training. And it's been very, very well received. Our training provider, which is Lancashire Mind, were able to mobilise very quickly and then deliver online training when the pandemic hit. And they're still doing that now, and we're getting excellent feedback. I'll let Vicki talk a bit about the orange button that's linked to. Do you want to go in there?
So what we did was we decided that, you know, training all these people is great, but the stigma that surrounds talking around suicide means that you need to know who these people are that are trained to actually identify them. And that's where the Orange Button community scheme began, through one of our very small charities in Lancaster. It was their idea that we adopted and created across the full patch. But basically, when some quality assured training in suicide prevention has taken place that has to be half a day or more, they receive the opportunity to get an orange button at the end, which is a pin badge to pop on your lanyard or your clothing that identifies you as someone who has been trained in suicide prevention or suicide awareness, and has a bit more confidence, isn't affected by the stigma surrounding it, and isn't going to run away if you mention the word suicide, because that is a massive fear for people to actually open up in the first place. And we've sent over 500 pin badge packs out already, and that was only launched on World Suicide Prevention Day, so it's moving quite well.
So obviously a key sort of area of the work that we've done as well is that it's co-produced. So in the first 2 years, we had an innovation project, which was small grants for innovative suicide prevention, self-harm targeted projects. What we did with that is we had people that had lived experience and someone that was bereaved by suicide on the panel that helped us to pick those grants and award that those small grants to those individual sort of grassroots voluntary sector organisations. Vicki has done some sterling work with bereaved by suicide. Do you want to talk a bit about that, Vic?
So we had some bereavement by suicide workshops, all with people sadly with lived experience of losing someone to suicide, and the outcomes from those groups were fantastic. I think there was over 80 projects that were identified, or 80 gaps that were identified, which we themed up into 8 different themes, which kind of built the work programme for the bereavement by suicide. It meant that we've created a directory of support across Lancashire and South Cumbria, broken down by district. But we've also enhanced that and popped a map on there, because it might not be in your district that there's a peer support group, but there's one in the next district, but you didn't know about it. One of the main things that came out of that was there is a lot of things available, but you're not in the right frame of mind to actually be searching and looking for those things, and people don't know where to turn. So one of the big things we've got now is to increase the knowledge within our GPs of what's available across the patch. So lots and lots of things came from that, and it wouldn't have looked the way it does now if we hadn't got that really valuable lived experience input. So
yeah, and it's worth noting, you know, we had lived experience males that helped develop our male suicide prevention campaign, which was around ending stigma. You know, they sort of gave us their viewpoint on some of the images that were used. So you know, it's really vital that you get co-produced, co-production running right the way through your programme.
Yeah, that's massive with the website as well, because the picture, I mean, we've all seen the stock images for mental health where it's head in hands, and, you know, they actually brought one of our parents to tears because that's how they think their son may have looked, you know. So without that knowledge, we would have gone with that image on our website and maybe inadvertently actually upset people. So, you know, it's really, really important to get that lived experience input. Okay. So this is from me. It's just a selection, very whirlwind. Some of the things that we've done in year 2. So that's our website up in the corner there. That's the image that we did pick, which was a very hopeful image. But you can see there the RTS system's up and running, training package in place, the campaign that Louise was talking about, the Keep Talking campaign. Help is at hand, one of the best and most underused resources ever. We have flooded the Lancashire and South Cumbria systems with Help is at hand. We have 10 copies in every public library now across the system as well. Obviously, they've been closed through COVID, but but they are there. Peer support groups, you can see there for bereavement. We had 2, and none of them were actually on our patch. They were just outside. And we've increased that now to 8, which are all in Lancashire and South Cumbria. The directory, the dual diagnosis pilot between our mental health trust and our substance misuse provider. We've got pilot running across 2 areas in Lancashire for our bereavement support service. That was in year 2. And the self-harm task and finish groups were all set up to look at a whole system, all age self-harm pathway. And then in year 3 was to embed, and we got the COVID-19 pandemic. So all those in bold are projects that came about because of the pandemic. The ones that aren't were going to happen anyway. So the Amparo support service is now fully commissioned across Lancashire. It was piloted in year 2, but now it's fully commissioned. Samaritan's bedside phone line is available on all our Hospedia phones. So in the acute trust wards, when visitation was cancelled, we made sure that there was access to the Samaritans for anyone who was stuck in hospital at that time. And that's still ongoing. The mental health listings, which are these pictures here, they're on our website for anybody to use and are regularly updated. We designed a campaign, which Louise can talk around in a minute, which was around mental health, suicide and support. All our bereavement groups turned to online, and we provided them with MS Teams as well, so that they had an option to get online. We had a coordinated digital comms package for World Suicide Prevention Day. That was led by Healthier Lancashire, but included the whole of our system. As we said earlier, the Orange Button scheme was launched, and our RTS reporting went from monthly to weekly to try and spot any urgent interventions that might be required. Okay, so Louise?
So how to start? So obviously what we've said, it's a whole system approach is needed to get this embedded and, sustained really throughout your ICS STP. It's a must do. We've got to stop suicide. We've got to get people to realise the impact, the devastating impact that suicide has on our communities. You can put a cost to it. Unfortunately, you can put a cost to anything. Every suicide costs the local economy between 1.6 and 1.7 million pounds. So if you need a business case to take to your leaders that are thinking suicide prevention, we can put that to one side, take that business case to them and show them the impact that has on the local community, the local economy, etc. More so now in a time of a pandemic when, we think and research is showing that perhaps suicide rates is going to increase, over the coming sort of 12, 18 months. COVID's not going away. It's going to be here, and we're going to feel the impact of it for a long, long time. Use, like Vicki said, what's already available. You've got health and wellbeing boards, community groups. You've got police colleagues within your local police forces that probably have a mental health remit. Engage with them and make sure that you're banging that drum. I think maybe some people in Lancashire and South Cumbria are sick of us lot because all we do is get on their agenda and talk about suicide prevention, but it really needs to be pushed up there as a priority area for all the communities involved.
Okay. And with lived experience, it's just so important that they're involved. We've not walked in their shoes, so you don't know exactly what's needed. And put the work in to find the people. It's one of those that we always said in the beginning, you don't walk around with a sandwich board saying how you've been affected by anything in life, but just put it out there. People will come to you. We used Twitter, we used Facebook, we used every method possible to get to people, and they wanted to be involved. I think this one's really important about don't put off by any negative experiences. A lot of the time when you think of patient or public involvement, it's sometimes just to air grievances about how things didn't go right for them or what was wrong for them. And that's par for the course when you work with lived experience, but they are sometimes the best things that can help to shape those future positives. Listen to everything. Some really good positives have taken place that we can replicate, and give people space to talk about their loved ones. It's very empowering, and it does bring it. It does give it a very reality check as to why we're doing the role we're doing as well. Okay. And then these learning points that Tom asked us for a couple of learning points, so we just bobbed these on, which were keep the plan fluid. So from my experience with the bereaved through suicide work, there was a list of things that we were going to do. And then we had our lived experience workshops and our professionals workshops, and we basically rewrote that element and decided there was other stuff that needed doing instead. So constantly revisit, don't get hung up on it says this on your plan, just keep re-looking at your plan.
And it's just worth noting there, what we found with this wave 1 of funding is this flexibility, flex it. Obviously, we've been hit by the global pandemic at the end of our year 3. And we've flexed a lot of our projects to make sure that our suicide prevention campaign has been running, that we're able to get information out to people. So we've flexed some of our budgets to make sure that